Welcome to this video entitled, Fungal Meningitis. Fungal meningitis is a serious infection that causes inflammation of the meninges, the protective membranes surrounding the brain and spinal cord. Unlike bacterial meningitis, which often develops suddenly and aggressively, fungal meningitis usually progresses more slowly over time. This slower pattern is why fungal meningitis is often described as subacute or chronic in onset. Symptoms may develop gradually over days, weeks, or even months before the condition is finally recognized. Patients commonly experience persistent headaches, fever, fatigue, nausea, and neck stiffness. As the infection progresses, confusion, personality changes, visual problems, seizures, or altered consciousness may develop. Because the symptoms appear slowly, fungal meningitis can easily be mistaken for migraines, viral infections, tuberculosis, or other neurological disorders. Delayed diagnosis is one of the major reasons the disease can become life-threatening. Fungal meningitis is caused by pathogenic fungi that invade the central nervous system. Common organisms include Cryptococcus, Histoplasma, Coccidioides, and Candida. Each fungus has different environmental sources and geographic patterns. An important point is that fungal meningitis is not contagious from person to person. You cannot catch it through casual contact, coughing, or sharing food with an infected individual. Instead, the infection usually begins somewhere else in the body, most commonly in the lungs. People often inhale fungal spores from the environment without realizing it. These spores are found in soil, bird droppings, decaying vegetation, or dusty environments depending on the fungal species involved. After entering the lungs, the fungi may spread through the bloodstream to the brain and meninges. Once inside the central nervous system, they trigger inflammation and neurological symptoms. Fungal meningitis is most commonly seen in immunocompromised individuals. People living with HIV, AIDS are especially vulnerable because weakened immune defenses make it harder to control fungal infections. Other high-risk groups include organ transplant recipients, cancer patients, and individuals taking immunosuppressive medications such as corticosteroids or chemotherapy drugs. However, fungal meningitis can also occur in immunocompetent individuals with otherwise healthy immune systems. Certain environmental exposures or highly virulent fungal strains can occasionally infect healthy people as well. One of the most common fungal causes worldwide is cryptococcal meningitis, particularly in patients with advanced HIV infection. This form of meningitis remains a major cause of mortality in many parts of the world. Diagnosis often requires cerebrospinal fluid analysis, fungal cultures, antigen testing, and brain imaging. Treatment typically involves prolonged antifungal therapy and careful management of intracranial pressure. Early recognition is extremely important because untreated fungal meningitis can lead to severe neurological injury, coma, or death. Although fungal meningitis develops more slowly than bacterial meningitis, it remains a medical emergency that requires prompt diagnosis and specialized treatment. Several different fungi can cause fungal meningitis, and each group affects patients in unique ways. Some fungi mainly attack people with weakened immune systems, while others can infect healthy individuals as well. One of the most important causes is Cryptococcus species. The two major types are Cryptococcus neoformans and Cryptococcus gattii. Cryptococcus neoformans is the most common cause of fungal meningitis worldwide. It mainly affects immunocompromised individuals, especially people living with advanced HIV, AIDS. The fungus is commonly found in soil contaminated with bird droppings, particularly pigeon droppings. After inhalation into the lungs, the fungus may spread through the bloodstream to the brain. Patients often develop chronic headaches, fever, confusion, and increased intracranial pressure. Cryptococcus gattii behaves somewhat differently. Unlike Cryptococcus neoformans, it can infect immunocompetent individuals with otherwise healthy immune systems. Outbreaks have been reported in the Pacific Northwest region of North America, drawing attention to its environmental spread. Another important group includes Candida species such as Candida albicans and Candida glabrata. These fungi are part of the normal human flora but can become invasive under certain conditions. Candida meningitis is most commonly seen in neonates, critically ill hospitalized patients, or individuals who have undergone neurosurgical procedures. Premature infants and patients with indwelling medical devices are especially vulnerable. Unlike cryptococcal meningitis, Candida infections often arise from bloodstream infections that spread into the central nervous system. Dimorphic fungi are another major category. These organisms exist in different forms depending on the environment and body temperature. Important examples include Coccidioides immitis, Histoplasma capsulatum, and Blastomyces dermatitidis. These fungi are geographically restricted. Coccidioides is mainly found in arid regions such as the southwestern United States. Histoplasma is associated with areas containing bird or bat droppings, especially river valleys. Blastomyces is more common in moist soil environments near waterways. Although these infections usually begin in the lungs, they can disseminate and involve the central nervous system, causing chronic meningitis or brain lesions. Molds can also cause severe fungal CNS infections. Aspergillus species are particularly dangerous in immunocompromised patients. These fungi can invade blood vessels, leading to strokes, hemorrhage, and rapidly progressive neurological disease. The mucorales group, including Rhizopus and Mucor, causes mucormycosis, an aggressive infection often seen in diabetic or severely immunosuppressed patients. These fungi can invade the sinuses, orbit, and brain with devastating speed. Demaciaceous fungi such as Xerohilum rostratum are less common but gained attention during outbreaks linked to contaminated medical injections. Understanding the major fungal causes of meningitis is important because diagnosis, treatment, and prognosis vary significantly between different organisms. One of the most alarming healthcare-associated infections in recent history was the iatrogenic fungal meningitis outbreak linked to contaminated steroid injections. The term, iatrogenic, means the disease was caused unintentionally through medical treatment or procedures. The main causative agent was Xerohilum rostratum, a rare demaciaceous fungus. Demaciaceous fungi are dark-walled molds that contain melanin in their cell walls, giving them a darker appearance under the microscope. Before this outbreak, Xerohilum rostratum was considered an uncommon human pathogen. Most doctors rarely encountered it in routine clinical practice. However, the outbreak demonstrated how dangerous environmental fungi can become when introduced directly into the human body. The source of the outbreak was contaminated preservative-free methylprednisolone vials produced by a single compounding pharmacy. Methylprednisolone is a corticosteroid commonly used to treat back pain and inflammation through epidural injections. Because the medication became contaminated during the compounding process, patients unknowingly received injections containing fungal spores. Transmission did not occur from person to person. Instead, the fungus entered directly into tissues during epidural or paraspinal steroid injections. This bypassed many of the body's normal protective barriers and allowed the fungus access to areas near the spinal cord and central nervous system. One of the most frightening aspects of the outbreak was the delayed presentation. Many patients initially felt normal after their injections. Symptoms often appeared 1 to 4 weeks later, making the connection to the procedure less obvious at first. Patients commonly developed meningitis with symptoms such as severe headache, fever, neck stiffness, nausea, and sensitivity to light. Unlike acute bacterial meningitis, the illness often progressed more slowly, which sometimes delayed diagnosis. Some patients experienced strokes involving the posterior circulation of the brain. This occurred because the fungal infection caused inflammation and damage to blood vessels supplying critical brain structures. Stroke symptoms included dizziness, weakness, difficulty speaking, visual disturbances, and altered consciousness. Others developed localized infections near the injection site. These included epidural abscesses, spinal osteomyelitis, or persistent back pain caused by fungal invasion of surrounding tissues. The outbreak highlighted major concerns regarding compounding pharmacy safety, sterile technique, and medication quality control. It also demonstrated how fungal meningitis can occur through direct medical exposure rather than traditional environmental inhalation. Diagnosis was challenging because many clinicians were unfamiliar with this unusual pathogen. Early recognition required a high level of suspicion, especially in patients with recent spinal injections and unexplained neurological symptoms. Treatment often involved prolonged antifungal therapy combined with neurosurgical management in severe cases. Recovery was difficult for many patients, and some suffered permanent neurological complications. This outbreak became a powerful reminder that even routine medical procedures can carry serious risks when sterility standards fail. Fungal infections of the central nervous system usually begin far away from the brain itself. In most cases, the process starts when a person inhales infectious fungal particles from the environment. These infectious propagules may be spores or yeast forms released from soil, bird droppings, decaying vegetation, or dusty environments. Many people inhale these organisms without ever realizing it. For certain fungi, exposure is surprisingly common. Areas contaminated with pigeon droppings, bat caves, construction sites, or dry soil can all serve as environmental reservoirs. Once inhaled, the fungi enter the lungs and establish a primary infection. In many individuals, this early pulmonary infection causes few or no symptoms at all. Some people may only experience mild cough, fatigue, or flu-like symptoms that resolve without medical attention. Because the initial lung infection is often asymptomatic, patients may have no idea they were ever exposed to the fungus. The real danger begins when the organism spreads beyond the lungs. Through the bloodstream, fungi can disseminate to distant organs, including the brain and meninges. This process is known as hematogenous dissemination. Some fungi may also spread from infected skin lesions or other body sites into the bloodstream before reaching the central nervous system. Once inside the brain, the fungi trigger inflammation of the meninges and surrounding tissues. This can lead to headaches, fever, neck stiffness, confusion, seizures, and increased intracranial pressure. One of the best studied fungal pathogens in CNS disease is Cryptococcus. This organism has evolved several remarkable mechanisms that allow it to cross the blood-brain barrier and invade the central nervous system. One method is called transcellular migration. In this process, the fungus passes directly through the cells lining blood vessels in the brain. Another mechanism is paracellular passage. Here, The organism squeezes between neighboring cells after disrupting tight junctions that normally protect the brain from infection. Perhaps the most fascinating mechanism is known as the Trojan horse strategy. In this process, Cryptococcus hides inside infected immune cells called phagocytes. These cells normally travel throughout the body to fight infection. Instead of destroying the fungus, the phagocytes unknowingly transport it across the blood-brain barrier into the central nervous system. The fungus essentially uses the body's own immune system as a vehicle for brain invasion. This ability to evade immune defenses makes cryptococcal meningitis especially dangerous in immunocompromised individuals, particularly patients with HIV/AIDS. Understanding fungal dissemination is important because it explains why central nervous system symptoms may appear long after the initial environmental exposure. A person may inhale fungal spores weeks or months before neurological disease develops. The pathogenesis of fungal meningitis highlights the complex interaction between environmental pathogens, immune defenses, and the protective barriers surrounding the brain. Fungal meningitis usually develops slowly compared to bacterial meningitis. Instead of causing sudden severe illness within hours, symptoms often appear gradually over days or weeks. This slower progression is why many patients delay seeking medical care. One of the most common symptoms is a prolonged headache. Patients often describe persistent headaches that continue getting worse over time. The pain may not respond well to routine medications and can become increasingly disabling. Low-grade fever is also common. Unlike the high fevers often seen in acute bacterial infections, fungal meningitis may cause only mild temperature elevation. This can make the illness seem less serious during the early stages. Many patients experience malaise, fatigue, and general weakness. They may feel constantly tired or notice reduced energy for daily activities. Weight loss can also occur, especially in chronic infections that progress over several weeks. As inflammation around the meninges increases, neurological symptoms begin to appear. Neck stiffness is one of the classic signs of meningeal irritation. Patients may have difficulty bending the neck forward because movement becomes painful. Nausea and vomiting are also frequent symptoms. These may develop because inflammation increases intracranial pressure inside the skull. Some patients become sensitive to bright light, a symptom known as photophobia. Photophobia occurs because inflamed meninges make the nervous system more sensitive to sensory stimulation. Patients may prefer dark rooms and avoid strong light exposure. As the infection advances, the central nervous system becomes more severely affected. Patients may develop altered mental status, including confusion, disorientation, memory problems, or personality changes. Cranial nerve palsies can also occur when inflammation compresses nerves near the base of the brain. This may lead to double vision, facial weakness, hearing problems, or difficulty swallowing depending on which cranial nerves are involved. Seizures may develop if fungal lesions or inflammation irritate the brain tissue directly. In severe cases, patients become lethargic, increasingly difficult to awaken, or even progress into coma. One important exception involves cryptococcal meningitis in patients with HIV infection. In these individuals, the immune system is often profoundly weakened, which changes how the body responds to infection. Because the inflammatory response is reduced, classic signs of meningitis may be surprisingly mild or even absent. Some HIV-infected patients with severe cryptococcal meningitis may have little neck stiffness or minimal meningeal irritation despite significant infection inside the brain. This lack of dramatic inflammation can delay diagnosis because the illness appears less obvious clinically. Instead, patients may mainly complain of persistent headache, fatigue, confusion, or subtle cognitive decline. The clinical presentation of fungal meningitis therefore varies widely depending on the organism involved and the patient's immune status. Recognizing these slower, chronic neurological symptoms is essential for early diagnosis and treatment. Even when symptoms appear mild at first, fungal meningitis can become life-threatening if left untreated. Cerebrospinal fluid analysis, often called CSF analysis, is one of the most important tools for diagnosing fungal meningitis. Because the cerebrospinal fluid surrounds the brain and spinal cord, changes in this fluid can reveal ongoing infection and inflammation inside the central nervous system. In severe cryptococcal meningitis, the CSF may sometimes appear abnormal even to the naked eye. A thick, gelatinous exudate can develop due to heavy fungal burden and inflammatory material within the fluid spaces surrounding the brain. This gelatinous appearance is especially associated with advanced cryptococcal disease and reflects the large amount of fungal polysaccharide capsule material released into the CSF. One of the key laboratory findings is lymphocytic pleocytosis. This means there is an increased number of white blood cells in the cerebrospinal fluid, with lymphocytes being the dominant cell type. Lymphocytes are commonly seen in chronic infections such as fungal meningitis and tuberculosis. Their presence signals that the immune system is responding to infection within the central nervous system. However, an important exception occurs in severely immunosuppressed patients, especially those with advanced HIV/AIDS. In these individuals, the immune system may be too weak to mount a strong inflammatory response. As a result, the CSF white blood cell count can sometimes appear normal or only minimally elevated despite severe cryptococcal infection. This can make diagnosis more challenging because the usual inflammatory signs may be absent. Another major CSF finding is low glucose, also known as hypoglycemia. Fungi and inflammatory cells consume glucose within the cerebrospinal fluid, while inflammation also interferes with normal glucose transport into the CSF. Low glucose levels are an important warning sign of serious central nervous system infection and are commonly seen in fungal and tuberculous meningitis. Protein levels in the CSF are also usually elevated. Inflammation damages the blood-brain barrier, allowing proteins to leak into the cerebrospinal fluid. Elevated protein reflects ongoing meningeal irritation and tissue injury. One of the most clinically important features in cryptococcal meningitis is elevated opening pressure during lumbar puncture. Opening pressure measures the pressure of cerebrospinal fluid within the spinal canal at the moment the needle enters the space. In cryptococcal meningitis, opening pressures are frequently very high, often greater than 250 millimeters of water. Some patients develop extremely severe intracranial hypertension. Elevated intracranial pressure can cause persistent headaches, nausea, vomiting, blurred vision, hearing changes, confusion, and cranial nerve palsies. If pressure becomes dangerously high, patients may develop coma or even brain herniation. Managing elevated pressure is therefore a critical part of treatment. Some patients require repeated therapeutic lumbar punctures or additional drainage procedures to relieve pressure and protect the brain. The CSF profile in fungal meningitis provides valuable diagnostic clues, but interpretation always depends on the patient's immune status and clinical presentation. Even subtle abnormalities can signal a serious and potentially life-threatening central nervous system infection. Diagnosing fungal meningitis requires careful laboratory testing because the symptoms often resemble other infections of the central nervous system. One of the first steps is examining the cerebrospinal fluid, or CSF, under the microscope. A classic test for cryptococcal meningitis is the India ink stain. In this method, a drop of cerebrospinal fluid is mixed with a dark dye and viewed microscopically. If Cryptococcus is present, the yeast cells appear as round budding organisms surrounded by a clear halo. This halo represents the thick polysaccharide capsule that protects the fungus from the immune system. The appearance is very distinctive and has been used for decades to diagnose cryptococcal infection. However, the sensitivity of India ink is lower in patients with small numbers of organisms, so a negative result does not completely exclude the disease. Today, one of the most important diagnostic tools is cryptococcal antigen testing, commonly called CRAG testing. This test detects components of the fungal capsule in the blood or cerebrospinal fluid. Cryptococcal antigen testing can be performed using latex agglutination or lateral flow assays. These methods are highly sensitive and highly specific, even in patients with low fungal burden. The lateral flow assay is especially valuable because it is rapid, easy to perform, and useful even in resource-limited settings. Results can often be available within minutes, allowing treatment to begin quickly. Culture remains the gold standard for confirming fungal infection. Cerebrospinal fluid samples are commonly placed on sabor or dextrose agar, a special medium that supports fungal growth. When fungi grow in culture, laboratories can identify the exact organism and sometimes determine antifungal susceptibility. This information helps guide treatment decisions. However, cultures may require several days to weeks, especially for dimorphic fungi such as Histoplasma or blastomyces. Because fungal meningitis can become life-threatening, doctors often begin treatment before culture confirmation is available. Modern laboratories increasingly use advanced molecular and proteomic techniques for rapid identification. Polymerase chain reaction, or PCR, detects fungal genetic material directly from clinical samples. PCR can help identify organisms quickly, even when cultures are still negative. This improves diagnostic speed and may allow earlier targeted therapy. Another advanced method is MALDI-TOF mass spectrometry. This technology identifies fungal species by analyzing unique protein patterns within the organism. MALDI-TOF has revolutionized microbiology laboratories because it can rapidly distinguish between different fungal species with remarkable accuracy. Fast identification is extremely important because different fungi require different antifungal medications and treatment durations. Early diagnosis can dramatically improve survival and reduce neurological complications. The laboratory diagnosis of fungal meningitis therefore combines traditional microscopy, antigen testing, fungal culture, and advanced molecular methods to detect these dangerous infections as quickly and accurately as possible. Neuroimaging plays a major role in diagnosing fungal meningitis and identifying complications inside the brain. Although CT scans are often performed first in emergency settings, contrast-enhanced MRI is considered the imaging modality of choice. MRI provides much clearer detail of the meninges, blood vessels, and brain tissue compared to CT. It is especially useful for detecting subtle inflammation, small lesions, and early neurological complications that may be missed on routine CT imaging. One of the common findings in fungal meningitis is bacillar meningeal enhancement. This occurs when inflamed meninges at the base of the brain become visible after contrast administration. The meninges appear brighter on MRI because inflammation disrupts the blood-brain barrier, allowing contrast material to leak into surrounding tissues. This finding reflects active meningeal infection and inflammation. Hydrocephalus is another important imaging feature. Inflammation can block the normal circulation and absorption of cerebrospinal fluid, causing fluid to accumulate inside the ventricles of the brain. As intracranial pressure rises, patients may develop worsening headaches, vomiting, blurred vision, confusion, or decreased consciousness. Severe hydrocephalus may require urgent drainage procedures to prevent brain injury. Cryptococcal meningitis has some unique imaging findings. One classic feature is dilated Virchow-Robin spaces, often called soap bubble lesions. Virchow-Robin spaces are tiny fluid-filled channels that surround blood vessels as they enter the brain. In cryptococcal infection, fungal organisms accumulate within these spaces, causing them to enlarge. On MRI, these dilated spaces create a clustered appearance that resembles soap bubbles scattered through deep brain structures such as the basal ganglia. Another cryptococcal finding is the presence of Cryptococcus. These are localized fungal mass lesions formed by collections of organisms and inflammatory tissue within the brain. Cryptococcus can behave like tumors and may cause seizures, focal weakness, headaches, or symptoms related to increased intracranial pressure depending on their size and location. Fungal infections can also produce serious vascular complications. Some fungi, especially molds like Aspergillus and Xerohilum, have a strong tendency to invade blood vessels directly. This vascular invasion can damage vessel walls, reduce blood flow, and trigger clot formation. As a result, patients may develop cerebral infarcts or strokes. These strokes can appear suddenly with weakness, speech problems, visual loss, altered consciousness, or paralysis depending on the affected brain region. Invasive mold infections are especially dangerous because they may progress rapidly and cause widespread vascular injury within the central nervous system. Neuroimaging therefore provides critical information not only for diagnosis, but also for assessing disease severity, identifying complications, and guiding treatment decisions. In fungal meningitis, MRI findings often reveal how deeply the infection has affected the brain long before irreversible neurological damage becomes clinically obvious. Treating cryptococcal meningitis requires a long-term, carefully structured antifungal strategy. Because the infection affects the brain and central nervous system, therapy is divided into several phases designed to rapidly control the fungus and prevent relapse. The first stage is called induction therapy. This is the most aggressive phase of treatment and usually lasts between 2 and 4 weeks. During induction therapy, patients receive amphotericin B together with flucytosine. Amphotericin B may be given in its conventional deoxycholate form or as a liposomal formulation. Amphotericin B is one of the most powerful antifungal medications available. It works by damaging the fungal cell membrane, leading to fungal cell death. The liposomal form is often preferred when available because it causes less kidney toxicity and fewer side effects compared to conventional amphotericin B deoxycholate. Flucytosine is added because combination therapy clears fungal organisms from the cerebrospinal fluid much faster than amphotericin B alone. Using both drugs together significantly improves treatment effectiveness. The goal of induction therapy is rapid reduction of fungal burden inside the central nervous system. This phase is critical because uncontrolled cryptococcal infection can quickly lead to severe intracranial pressure, coma, or death. After induction therapy, patients move into consolidation therapy. This phase usually lasts for about 8 weeks. During consolidation therapy, high-dose fluconazole is used. Fluconazole is an antifungal medication with excellent penetration into the cerebrospinal fluid and brain tissue. At this stage, the fungal burden has already been reduced substantially, so fluconazole helps eliminate remaining organisms and stabilize recovery. Once consolidation therapy is completed, patients enter maintenance therapy, sometimes called secondary prophylaxis. Lower dose fluconazole is continued for up to 1 year in many patients. This prolonged therapy is especially important in individuals with HIV/AIDS because relapse rates are high if treatment stops too early. Maintenance therapy usually continues until the patient's immune system improves, particularly when the CD4 count rises above 100 cells per cubic millimeter after effective antiretroviral therapy. The recovery of immune function is essential because antifungal drugs alone may not provide long-term protection if severe immunosuppression persists. In many parts of the world, access to amphotericin B or flu cytosine may be limited. In these resource-constrained settings, alternative treatment strategies are sometimes necessary. One commonly used alternative involves high-dose fluconazole combined with flu cytosine. Although this regimen may not clear infection as rapidly as amphotericin B-based therapy, it can still be effective when standard medications are unavailable. Managing cryptococcal meningitis also requires close monitoring for complications such as elevated intracranial pressure, medication toxicity, electrolyte disturbances, and immune reconstitution inflammatory syndrome. Even with treatment, cryptococcal meningitis remains a life-threatening disease. Early diagnosis, rapid antifungal therapy, and long-term follow-up are essential for improving survival and reducing neurological complications. Different types of fungal meningitis require different antifungal treatments. The choice of medication depends on the specific fungus involved, the severity of infection, and the patient's immune status. One important form is coccidioidal meningitis, caused by Coccidioides species. This fungus is commonly found in dry desert regions such as the southwestern United States. When the infection spreads to the central nervous system, long-term treatment becomes necessary. Fluconazole is considered the drug of choice because it penetrates the cerebrospinal fluid effectively and is generally well tolerated. Unlike some other fungal infections, coccidioidal meningitis often requires lifelong therapy. This is because the fungus has a strong tendency to relapse if antifungal treatment is stopped too early. Patients may remain clinically stable for years on continuous fluconazole therapy, but close monitoring is still essential. Histoplasmosis and blastomycosis can also involve the central nervous system. These infections are caused by Histoplasma capsulatum and Blastomyces dermatitidis. In severe CNS disease, initial treatment usually begins with liposomal amphotericin B. This powerful antifungal rapidly reduces fungal burden during the acute phase of illness. Once the patient stabilizes, therapy transitions to long-term itraconazole. Itraconazole helps suppress residual infection and prevent relapse over extended periods. Because these fungi can disseminate widely through the body, treatment often continues for many months. Candida meningitis is another important fungal CNS infection. It is most commonly seen in neonates, neurosurgical patients, or critically ill hospitalized individuals. Treatment usually involves liposomal amphotericin B, sometimes combined with flu cytosine for additional antifungal activity. Once the infection improves, patients are often transitioned to fluconazole for ongoing therapy. This step-down approach allows prolonged treatment with a medication that is easier to tolerate long-term. Mold infections are among the most aggressive fungal diseases affecting the central nervous system. Aspergillus species are especially dangerous because they invade blood vessels and can cause strokes, hemorrhage, and widespread brain injury. Voriconazole is considered the preferred treatment for invasive aspergillosis involving the brain. It has strong activity against Aspergillus and penetrates CNS tissues effectively. Mucormycosis is another devastating mold infection caused by organisms such as Rhizopus and mucor. These fungi grow rapidly and aggressively invade tissue and blood vessels. Treatment requires liposomal amphotericin B combined with urgent surgical debridement. Surgery is often necessary because dead infected tissue prevents antifungal drugs from reaching the organisms effectively. Managing fungal meningitis is often complex and prolonged. Many patients require months or even lifelong antifungal therapy depending on the organism involved. Close monitoring is essential because antifungal medications can cause kidney injury, liver toxicity, electrolyte disturbances, and other complications. Early diagnosis and organism-specific treatment are critical because delays can lead to irreversible neurological damage or death. Managing complications in fungal meningitis is just as important as treating the infection itself. In many patients, the complications are actually what become life-threatening. One of the most dangerous complications is elevated intracranial pressure, often called increased ICP. This means pressure inside the skull rises because cerebrospinal fluid cannot circulate or drain normally. Cryptococcal meningitis is especially known for causing severe intracranial hypertension. Patients may develop intense headaches, nausea, vomiting, blurred vision, hearing changes, confusion, or difficulty staying awake. If the pressure becomes too high, it can compress brain tissue and reduce blood flow to vital structures. Without rapid treatment, elevated intracranial pressure can lead to coma or death. Managing intracranial pressure is therefore critical for survival. One of the most effective treatments is repeated large-volume lumbar punctures. During these procedures, doctors remove excess cerebrospinal fluid to temporarily lower pressure inside the skull. Some patients require daily lumbar punctures until pressure stabilizes. In more severe cases, temporary lumbar drains may be inserted to continuously remove cerebrospinal fluid over time. If pressure remains persistently elevated, a ventriculoperitoneal shunt may be necessary. A ventriculoperitoneal shunt, often called a VP shunt, is a surgical device that diverts excess cerebrospinal fluid from the brain into the abdominal cavity where it can be absorbed safely. Another major complication is immune reconstitution inflammatory syndrome, or IRIS. This condition commonly occurs in patients with HIV who begin antiretroviral therapy, or ART, while being treated for cryptococcal meningitis. As the immune system begins to recover, it suddenly mounts a stronger inflammatory response against the fungal infection. Ironically, patients may worsen clinically even though the antifungal treatment is working. Symptoms of immune reconstitution inflammatory syndrome may include worsening headaches, fever, confusion, seizures, enlarging brain lesions, or increased intracranial pressure. This paradoxical deterioration can be frightening because it may resemble treatment failure or progression of infection. To reduce the risk of immune reconstitution inflammatory syndrome, doctors usually delay the start of antiretroviral therapy after beginning antifungal treatment for cryptococcal meningitis. The timing varies, but ART is often delayed for about 2 to 10 weeks depending on the patient's condition and fungal burden. This delay allows the fungal infection to come under better control before the immune system begins recovering aggressively. If severe immune reconstitution inflammatory syndrome develops, short courses of corticosteroids may be used to reduce dangerous inflammation within the central nervous system. These medications help control swelling and immune-mediated tissue damage while antifungal therapy continues. Managing fungal meningitis therefore involves much more than simply prescribing antifungal drugs. Doctors must constantly monitor intracranial pressure, neurological status, immune recovery, and inflammatory complications. In many cases, successful treatment depends on controlling the body's response to infection just as much as controlling the fungus itself. One of the hallmark laboratory findings in cryptococcal meningitis is the appearance of the organism on an India ink preparation of cerebrospinal fluid. This classic microbiology test has been used for decades to help identify Cryptococcus neoformans. The correct answer is C. Encapsulated budding yeasts with a clear halo. Here's why this appearance is so characteristic. Cryptococcus neoformans is a yeast that possesses a thick polysaccharide capsule surrounding the organism. This capsule is one of its major virulence factors because it helps the fungus evade the immune system and survive inside the human body. During an India ink preparation, the dark ink stains the background but does not penetrate the capsule itself. As a result, the yeast cell becomes visible as a round budding organism surrounded by a bright, clear halo against the dark background. That halo is actually the capsule. This halo sign is considered one of the classic visual clues for cryptococcal meningitis, especially in patients with HIV, AIDS or severe immunosuppression. The budding pattern is also important. Cryptococcus reproduces by narrow-based budding, meaning the daughter yeast emerges from a small attachment point on the parent cell. Now let's examine why the other options are incorrect. Option A, thick-walled broad-based budding yeasts, describes Blastomyces dermatitidis. Blastomyces has a very different budding pattern and does not produce the classic India ink halo seen with Cryptococcus. Option B, spherules filled with endospores, describes Coccidioides immitis. In tissue, this fungus forms large spherules packed with internal endospores rather than budding yeast cells. Option D, branching septate hyphae, is characteristic of molds such as Aspergillus species. Hyphae are long filamentous structures, not yeast forms. Although India ink staining is historically important, modern diagnosis now relies heavily on cryptococcal antigen testing, or CRAG testing, because it is far more sensitive and can detect infection even when only small numbers of organisms are present. Still, the India ink finding remains one of the most recognizable images in infectious disease microbiology. When clinicians or students see encapsulated budding yeasts surrounded by a clear halo in cerebrospinal fluid, cryptococcal meningitis immediately becomes the leading diagnosis. The correct answer is B. Xerohilum rostratum. This organism was the primary cause of the 2012 multi-state fungal meningitis outbreak linked to contaminated epidural methylprednisolone injections in the United States. The outbreak became one of the most serious healthcare-associated fungal infection events in modern medical history. Xerohilum rostratum is a demaciaceous fungus, also known as a dark-walled mold. These fungi contain melanin within their cell walls, giving them a dark appearance under microscopic examination. Before this outbreak, Xerohilum rostratum was considered a relatively uncommon human pathogen. Most clinicians rarely encountered it in routine practice. The outbreak began when preservative-free methylprednisolone vials produced by a compounding pharmacy became contaminated during manufacturing. Patients received epidural or paraspinal steroid injections intended to treat back pain and inflammation. Unfortunately, the contaminated medication introduced fungal spores directly into tissues near the spinal cord and central nervous system. Unlike typical fungal infections that begin through inhalation into the lungs, this outbreak involved direct inoculation during a medical procedure. Patients often developed symptoms 1 to 4 weeks after receiving injections. This delayed onset made the connection to the procedure difficult to recognize initially. Many patients presented with meningitis symptoms such as severe headache, fever, neck stiffness, nausea, vomiting, and photophobia. Others developed strokes involving the posterior circulation of the brain. The fungus invaded blood vessels, causing inflammation, clot formation, and interruption of blood flow to critical brain regions. Some individuals developed localized spinal infections, epidural abscesses, or persistent back pain at the injection site. Now let's look at why the other options are incorrect. Option A, Coccidioides immitis, causes coccidioidomycosis, also known as valley fever. It is associated with desert environments and was not responsible for the outbreak. Option C, Cryptococcus gatti, is a fungal pathogen known for causing meningitis in immunocompetent individuals, especially in the Pacific Northwest, but it was unrelated to the contaminated steroid injections. Option D, Aspergillus fumigatus, is a major cause of invasive mold infections in immunocompromised patients, but it was not the primary organism identified in the 2012 outbreak. This outbreak highlighted the importance of sterile pharmaceutical compounding practices and careful infection control measures. It also demonstrated how environmental fungi can become highly dangerous when introduced directly into the human body through medical procedures. The 2012 fungal meningitis outbreak remains a landmark event in infectious disease and public health history. The correct answer is B. Lymphocytic pleocytosis, low glucose, and elevated protein. This cerebrospinal fluid profile is the classic pattern seen in most cases of fungal meningitis. Let's break down why these findings occur. First, fungal meningitis usually causes lymphocytic pleocytosis. This means the CSF contains an increased number of white blood cells, mainly lymphocytes. Lymphocytes are commonly associated with chronic or subacute infections. Unlike acute bacterial meningitis, which often produces a strong neutrophilic response, fungal infections usually trigger a slower immune reaction dominated by lymphocytes. This lymphocytic pattern is also seen in tuberculosis meningitis, which is why the two conditions can sometimes look very similar clinically. The second major finding is low glucose, also called hypoglycemia. Fungi and inflammatory cells consume glucose inside the cerebrospinal fluid. Inflammation also interferes with normal glucose transport into the CSF. As a result, CSF glucose levels drop below normal. Low CSF glucose is an important warning sign because it strongly suggests a serious central nervous system infection rather than a simple viral illness. The third characteristic finding is elevated protein. Inflammation damages the blood-brain barrier and allows proteins to leak into the cerebrospinal fluid. Higher protein levels reflect ongoing meningeal irritation and tissue injury within the central nervous system. This combination of lymphocytic pleocytosis, low glucose, and elevated protein strongly points toward chronic meningitis caused by fungi or tuberculosis. Now let's examine why the other options are incorrect. Option A describes neutrophilic pleocytosis with normal glucose and protein. This pattern is more typical of early bacterial meningitis, not fungal meningitis. Option C shows a normal cell count with high glucose and low protein. This profile is essentially inconsistent with active meningitis and would not fit fungal CNS infection. Option D describes eosinophilic pleocytosis. Eosinophils in the CSF are uncommon and are more strongly associated with parasitic infections, certain medications, or rare fungal pathogens rather than the typical presentation of fungal meningitis. There is one important clinical nuance to remember. In severely immunocompromised patients, especially those with advanced HIV, AIDS, the inflammatory response may be very weak. In cryptococcal meningitis, some patients may actually have minimal white blood cells in the CSF despite severe infection. This happens because the immune system is too suppressed to mount a strong response. That is why fungal meningitis can sometimes be deceptively subtle on laboratory testing. Recognizing the classic CSF pattern is essential because early diagnosis and antifungal treatment can dramatically improve survival and reduce permanent neurological complications. The correct answer is C, liposomal amphotericin B and flu cytosine. This combination is considered the preferred induction therapy for severe cryptococcal meningoencephalitis, especially in patients with HIV infection. Cryptococcal meningitis is one of the most serious opportunistic infections seen in advanced HIV, AIDS. Without rapid treatment, the infection can quickly lead to elevated intracranial pressure, coma, and death. That is why the first phase of treatment, called induction therapy, is designed to aggressively reduce the fungal burden inside the brain and cerebrospinal fluid. Liposomal amphotericin B is one of the most powerful antifungal medications available. It works by binding to ergosterol within the fungal cell membrane, creating pores that cause the fungal cells to die. The liposomal formulation is preferred because it causes less kidney toxicity and fewer infusion-related side effects compared to conventional amphotericin B deoxycholate. Flu cytosine is added because combination therapy works far better than amphotericin B alone. Flu cytosine interferes with fungal DNA and RNA synthesis, helping suppress fungal replication. Together, these two medications clear Cryptococcus from the cerebrospinal fluid more rapidly and improve survival outcomes. Induction therapy usually lasts about 2 weeks, although severe disease may require a longer course depending on the patient's clinical response. After induction therapy, patients transition to consolidation therapy with high-dose fluconazole, followed later by maintenance therapy with lower-dose fluconazole to prevent relapse. Now let's look at why the other options are incorrect. Option A, fluconazole monotherapy, is generally not adequate for severe cryptococcal meningoencephalitis. Although fluconazole is an important antifungal drug, using it alone during the induction phase results in slower fungal clearance and poorer outcomes in severe disease. Option B, voriconazole and caspofungin, is not standard therapy for cryptococcal meningitis. Voriconazole is mainly used for invasive aspergillosis, while caspofungin has limited activity against Cryptococcus. Option D, itraconazole and dexamethasone, is also incorrect. Itraconazole is not the preferred treatment for cryptococcal CNS infection, and corticosteroids are not routinely used unless specific complications such as severe iris occur. Another major challenge in cryptococcal meningitis is elevated intracranial pressure. Many HIV-infected patients require repeated lumbar punctures to relieve pressure and reduce neurological complications during treatment. Doctors must also carefully time the initiation of antiretroviral therapy because starting ART too early may trigger immune reconstitution inflammatory syndrome, or IRIS. In cryptococcal meningoencephalitis, rapid diagnosis and aggressive induction therapy can dramatically improve survival and neurological recovery. The correct answer is C. Hematogenous spread from a primary infection site after inhalation of environmental spores. This is the typical pathway by which fungal meningitis develops in humans. Most fungal organisms that cause meningitis are found naturally in the environment. Their spores may exist in soil, bird droppings, decaying vegetation, construction dust, or dry desert regions depending on the fungal species involved. People usually become infected by inhaling these microscopic fungal spores into the lungs. In many cases, the initial lung infection causes few or no symptoms. Some individuals may only experience mild cough, fatigue, or flu-like illness and never realize they were exposed. After establishing a primary focus in the lungs, the fungi can spread through the bloodstream to other parts of the body. This process is called hematogenous dissemination. When the organisms reach the brain and meninges, they trigger inflammation within the central nervous system, leading to fungal meningitis. This route of spread is especially common with organisms such as Cryptococcus neoformans, Histoplasma capsulatum, and Coccidioides immitis. For example, Cryptococcus is commonly associated with soil contaminated by pigeon droppings. After inhalation, the fungus may remain dormant or eventually disseminate to the brain, especially in immunocompromised individuals. Patients with HIV, AIDS, organ transplants, cancer, or immunosuppressive therapy are particularly vulnerable because weakened immune defenses make it easier for fungi to spread beyond the lungs. Now let's examine why the other options are incorrect. Option A, person-to-person transmission through respiratory droplets, is not the typical mode of spread for fungal meningitis. Unlike bacterial meningitis caused by organisms such as Neisseria meningitidis, fungal meningitis is generally not contagious between people. You cannot usually catch fungal meningitis from someone through coughing, sneezing, or close contact. Option B, fecal-oral contamination, is associated with certain gastrointestinal infections, but not with the usual pathogenesis of fungal meningitis. Option D, direct skin-to-skin contact, is also incorrect. Fungal meningitis does not spread through casual touch or skin contact with infected individuals. There are rare exceptions involving direct inoculation during medical procedures, such as the 2012 fungal meningitis outbreak caused by contaminated steroid injections. In those cases, fungi entered the body directly instead of through inhalation. However, under normal circumstances, inhalation followed by bloodstream dissemination remains the classic mechanism of transmission. Understanding this pathway is important because it explains why environmental exposure plays such a major role in fungal disease. Many dangerous fungi are naturally present in the environment, but serious CNS infection usually develops only when the organism successfully spreads beyond the lungs into the bloodstream and brain. The correct answer is A. Cryptococcus gatti. This fungal pathogen is well known for its association with eucalyptus trees and for causing serious meningoencephalitis in immunocompetent individuals. Unlike many opportunistic fungal infections that mainly affect people with weakened immune systems, Cryptococcus gattii has the unusual ability to infect otherwise healthy hosts. This characteristic made it especially important during outbreaks reported in the Pacific Northwest region of North America, including areas of Canada and the northwestern United States. Researchers discovered that the fungus had established itself in local environmental reservoirs, including certain tree species and surrounding soil. Eucalyptus trees became strongly associated with Cryptococcus gattii because the organism was first linked to these trees in Australia. However, the fungus can also survive in other environmental settings. Humans usually acquire the infection by inhaling airborne fungal spores from the environment. The spores first enter the lungs and may establish a mild or even asymptomatic pulmonary infection. In some patients, the fungus spreads through the bloodstream to the central nervous system, causing meningitis or meningoencephalitis. Patients may develop chronic headaches, fever, confusion, visual disturbances, seizures, or altered mental status. Because the disease often progresses slowly, diagnosis may be delayed. One striking feature of Cryptococcus gattii infection is its tendency to form cryptococcomas. These are localized fungal mass lesions within the brain or lungs. Cryptococcomas can behave like tumors on imaging studies and may cause focal neurological deficits depending on their location. Now let's examine why the other options are incorrect. Option B, Cryptococcus neoformans, is another major cause of cryptococcal meningitis, but it primarily affects immunocompromised individuals, especially patients with advanced HIV/AIDS. Cryptococcus neoformans is more strongly associated with pigeon droppings and urban environmental exposure rather than eucalyptus trees. Option C, Candida albicans, is part of the normal human flora and mainly causes opportunistic infections in hospitalized or immunocompromised patients. It is not linked to Pacific Northwest outbreaks or eucalyptus exposure. Option D, Blastomyces dermatitidis, is a dimorphic fungus found in moist soil and wooded environments, particularly near waterways. Although it can involve the central nervous system, it is not associated with eucalyptus trees or the Pacific Northwest cryptococcal outbreaks. The emergence of Cryptococcus gattii highlighted how environmental fungal pathogens can adapt to new geographic regions and infect healthy populations. It also reminded clinicians that serious fungal meningoencephalitis is not limited to immunocompromised patients. Even healthy individuals can develop severe CNS infection after environmental exposure to certain pathogenic fungi. The correct answer is B, immune reconstitution inflammatory syndrome, or IRIS. This is a classic presentation of cryptococcal immune reconstitution inflammatory syndrome occurring after the initiation of highly active antiretroviral therapy, also known as HART. At first, this situation can seem very confusing. The patient is already receiving antifungal treatment, yet neurological symptoms suddenly worsen instead of improving. But in immune reconstitution inflammatory syndrome, the problem is not usually uncontrolled fungal growth. The problem is an exaggerated immune response. In patients with advanced HIV infection, the immune system is often severely weakened. Because of this, the body may initially produce very little inflammation even when a serious fungal infection like cryptococcal meningitis is present. Once HART is started, the immune system begins to recover. CD4 cells increase, immune activity improves, and the body suddenly recognizes fungal antigens that were previously ignored. This rapid immune recovery can trigger intense inflammation inside the central nervous system. As a result, patients may develop worsening headaches, fever, confusion, seizures, enlarged brain lesions, or dramatically increased intracranial pressure. New lymphadenopathy, meaning enlarged lymph nodes, can also occur because the recovering immune system becomes highly reactive throughout the body. One important feature of immune reconstitution inflammatory syndrome is the timing. Symptoms commonly appear several weeks after starting antiretroviral therapy, often within the first 1 to 2 months. The paradoxical worsening despite antifungal therapy is a major clue pointing toward immune reconstitution inflammatory syndrome rather than treatment failure. Now let's examine why the other options are incorrect. Option A, antifungal drug resistance, would usually involve persistent fungal growth despite therapy. In those cases, cultures may remain positive, and the infection itself continues progressing because the organism is no longer responding to medication. Option C, secondary bacterial meningitis, would typically produce signs of acute bacterial infection such as high fever, neutrophilic cerebrospinal fluid findings, and rapidly worsening systemic illness. Option D, relapse from medication non-compliance, is possible in cryptococcal disease, but would not classically appear immediately after starting heart with widespread inflammatory findings and new lymphadenopathy. Managing immune reconstitution inflammatory syndrome can be challenging because doctors must balance immune recovery with control of inflammation. In severe cases, corticosteroids may be used temporarily to reduce dangerous CNS inflammation. At the same time, antifungal therapy is usually continued because the underlying infection still requires treatment. This is also why clinicians often delay the initiation of heart for a short period after starting antifungal therapy in cryptococcal meningitis. Delaying immune recovery slightly can reduce the risk of severe immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome highlights one of the most fascinating paradoxes in medicine. Sometimes patients worsen not because the immune system is failing, but because it is suddenly becoming active again. The correct answer is B. Repeated daily therapeutic lumbar punctures or CSF shunting. Managing elevated intracranial pressure, or ICP, is one of the most important parts of treating cryptococcal meningitis. In many patients, uncontrolled intracranial pressure is a major cause of neurological deterioration and death. Cryptococcus can block the normal circulation and absorption of cerebrospinal fluid, causing pressure to build up inside the skull. The fungal capsule material may also obstruct normal CSF pathways, making the problem even worse. Patients with elevated intracranial pressure often develop severe headaches, nausea, vomiting, blurred vision, hearing changes, confusion, cranial nerve palsies, or difficulty staying awake. If the pressure continues rising, brain tissue can become compressed, blood flow may decrease, and life-threatening complications such as coma or brain herniation can occur. One of the most effective treatments is repeated therapeutic lumbar punctures. During these procedures, doctors remove large amounts of cerebrospinal fluid to temporarily lower intracranial pressure. Some patients require daily lumbar punctures, especially during the early phase of severe cryptococcal meningitis. If elevated pressure remains persistent or difficult to control, additional drainage procedures may be necessary. Lumbar drains or ventriculoperitoneal shunts can continuously divert excess cerebrospinal fluid away from the brain. A ventriculoperitoneal shunt, often called AVP shunt, moves fluid from the brain's ventricles into the abdominal cavity, where the body can safely absorb it. Now let's examine why the other options are incorrect. Option A, high-dose intravenous corticosteroids, is not considered standard treatment for elevated intracranial pressure in cryptococcal meningitis. Steroids may sometimes be used for severe immune reconstitution inflammatory syndrome, or IRIS, but they do not effectively solve the underlying CSF pressure problem. Option C, intravenous mannitol and hyperventilation, may temporarily reduce intracranial pressure in acute traumatic brain injury or severe cerebral edema, but they are generally not effective long-term solutions for cryptococcal meningitis-related pressure elevation. The major issue in cryptococcal disease is impaired cerebrospinal fluid drainage, not simply generalized brain swelling. Option D, switching from amphotericin B to fluconazole, would not address intracranial pressure and could actually weaken antifungal therapy during severe infection. One critical concept in cryptococcal meningitis is that antifungal medications alone are often not enough. Even if the fungus is being treated properly, elevated intracranial pressure can still cause devastating neurological damage. This is why careful monitoring of opening pressure during lumbar puncture is essential in these patients. In cryptococcal meningitis, relieving pressure can be just as life-saving as the antifungal drugs themselves. The correct answer is D, Candida albicans. Candida albicans is one of the most common causes of fungal meningitis in premature, very low birth weight neonates, especially those receiving intensive hospital care. Premature infants are particularly vulnerable because their immune systems are still immature and not fully developed. Their skin and mucosal barriers are also fragile, making it easier for organisms to enter the bloodstream. In neonatal intensive care units, many premature infants require life-saving medical support such as central venous catheters, intravenous nutrition, mechanical ventilation, and prolonged antibiotic therapy. While these interventions are often essential, they also increase the risk of invasive fungal infection. Candida species are part of the normal human flora and commonly live on the skin, in the gastrointestinal tract, and on mucosal surfaces. Under certain conditions, however, they can become invasive pathogens. Indwelling central venous catheters provide a direct route for Candida to enter the bloodstream. Once bloodstream infection develops, the fungus can spread hematogenously to multiple organs, including the brain and meninges. Very low birth weight neonates are especially at risk because they often require prolonged catheter use and intensive supportive care. Candida meningitis in neonates may present with nonspecific symptoms such as temperature instability, feeding difficulties, apnea, lethargy, irritability, seizures, or bulging fontanelles. Because symptoms can be subtle, diagnosis is often delayed unless clinicians maintain a high level of suspicion. Treatment usually involves liposomal amphotericin B, sometimes combined with flucytosine, followed later by fluconazole once the infection improves. Removing infected central venous catheters is also extremely important because persistent fungal colonization of the catheter can continue seeding the bloodstream. Now let's examine why the other options are incorrect. Option A, Histoplasma capsulatum, is a dimorphic fungus associated with bird and bat droppings. It can cause disseminated disease, but it is not the typical cause of neonatal fungal meningitis linked to catheters. Option B, Cryptococcus neoformans, mainly affects immunocompromised adults, especially patients with advanced HIV, AIDS, rather than premature neonates. Option C, Coccidioides immitis, causes coccidioidomycosis and is associated with desert regions such as the southwestern United States. It is not commonly linked to neonatal ICU infections. The association between Candida albicans, prematurity, and indwelling central venous catheters highlights the importance of infection prevention in neonatal intensive care units. Strict sterile technique, careful catheter management, and early recognition of invasive fungal infection are critical for protecting these highly vulnerable infants. In neonatal fungal meningitis, early diagnosis and rapid antifungal treatment can significantly improve survival and neurological outcomes. The correct answer is D. Lifelong. Coccidioidal meningitis is one of the most serious forms of infection caused by Coccidioides species, the fungi responsible for valley fever. Once the infection spreads to the central nervous system, it becomes a chronic and highly persistent disease. Unlike many other fungal infections, coccidioidal meningitis has a very high risk of relapse if antifungal treatment is stopped. Because of this, patients typically require lifelong oral fluconazole therapy. Fluconazole is considered the drug of choice because it penetrates the cerebrospinal fluid effectively and can suppress fungal growth within the meninges and brain. The medication does not completely eradicate the organism in most cases. Instead, it suppresses the infection and prevents progression or recurrence. If treatment is discontinued, dormant fungal organisms can reactivate, leading to recurrent meningitis and potentially life-threatening neurological complications. Patients with coccidioidal meningitis commonly present with chronic headaches, fever, nausea, neck stiffness, confusion, or cranial nerve abnormalities. The disease often develops gradually, making diagnosis difficult in the early stages. Hydrocephalus is a particularly important complication. Inflammation can obstruct cerebrospinal fluid pathways, causing elevated intracranial pressure and worsening neurological symptoms. Some patients may require ventriculoperitoneal shunts to control persistent hydrocephalus. The disease is most strongly associated with arid desert regions such as the southwestern United States, especially Arizona and California's San Joaquin Valley. People become infected by inhaling airborne fungal spores from disturbed soil. Many individuals develop only mild pulmonary illness, but in some patients, the infection disseminates through the bloodstream to the central nervous system. Now let's examine why the other options are incorrect. Option A, 2 weeks, is far too short for any form of fungal meningitis treatment. Option B, 8 weeks, is also insufficient because coccidioidal meningitis requires chronic suppression rather than short-term therapy. Option C, 6 to 12 months, may be appropriate for some systemic fungal infections, but CNS coccidioidomycosis has such a high relapse rate that therapy is generally continued indefinitely. Long-term monitoring is also essential because patients may experience medication side effects, relapse, or complications related to chronic meningeal inflammation. The need for lifelong fluconazole highlights how difficult central nervous system fungal infections can be to fully eradicate. In coccidioidal meningitis, treatment is often focused not only on controlling active infection, but also on preventing recurrence for the rest of the patient's life.